Good morning. Thank you so much for having me here today. So I'll be discussing emerging antimicrobial resistance. And my talk is new antimicrobial agents, no problem. The main part there is the big question mark, and Patrice kind of stole a little bit of my thunder there, giving some of that away. But I will discuss, I'm a clinical microbiologist at Johns Hopkins University, so I'll discuss much of my research is translational. And so how studying mechanisms of resistance can impact what we do in the clinical laboratory in terms of laboratory testing, but also treatment guidance and how we could use that information to impact that. So here are my disclosures. My biggest disclosure is, like Patrice, I am team gram-negative. And so a lot of my focus today is going to be on gram-negative, on resistance in gram-negative organisms. So I'm going to discuss mechanisms of resistance to novel agents pre and post clinical launch for the treatment of multi-drug resistant gram-negative infections. Describe how we can define studying the basis of the mechanism of resistance combined with clinical data to try to allow us to explore factors contributing to the emergence of resistance and potential risk factors that we can modify clinically to prevent the emergence of resistance, and show you some examples of how we use this information to guide clinical care. So you're probably going to hear these statistics over and over again today in an AMR-focused conference, but it is one of the biggest global health issues that we're currently faced with. It's a leading cause of death, in particular in resource-limited settings. And although we know it's a large global health issue, the precise magnitude is still really not well understood. The most recent estimates that were published in Lancet in 2022 or from data from 2019 were about 5 million deaths are associated with AMR annually, with 1.3 million deaths specifically attributed to resistance. And so global collective action is required. And there are many initiatives that have been described on how we can address antimicrobial resistance. And I'll focus on two today in my talk. One is improving surveillance of antimicrobial resistance, not only knowing how common it is, but what are the mechanisms mediating resistance. And then discussing how expanding and supporting development of new antimicrobial agents can help us address this important threat. So as we know through the years, the bugs are always smarter than the drugs. So on the top part of my arrow is when antibiotics were deployed for clinical use. And on the bottom part of the arrow is when we observe the emergence of resistance with these agents. Luckily, we've seen many new beta-lactam combination agents for the treatment of multi-drug resistant gram-negative infections. However, is that going to solve all of our problems? Unlikely, that is not the case, and I'll show you some examples in my presentation today, as we're already seeing with the deployment of these new drugs, the emergence of resistance. The one thing you got to keep in mind with these new agents for multi-drug resistant gram-negatives is that they have specific niches for therapy. So some of them cover most of your multi-drug resistant gram-negative infections, like ceftriaxone potentially covers, your carbapenem-resistant Enterobacterales, your Pseudomonas aeruginosa, your Acinetobacter and Stenotrophomonas multifida, as well as all carbapenemase types it could potentially have activity against. Whereas some of your ceftaz-avi, meropenem vibrobactam, imipenem relbactam are more for carbapenemase producers and have specific niches in there. All three of them do not cover metallobeta-lactamase producers like NDM. And then another example is ceftolozane tazobactam, which is mostly an anti-pseudomonal drug that we think of, doesn't cover carbapenemase producers. So just kind of giving you the landscape of these agents and that they do have specific niches. So now it's important for us to kind of understand mechanisms mediating resistance because it helps us in guiding the utilization of these agents. So we're going to start with ceftolozane tazobactam and kind of walk through some stories of pre-clinical use and post-clinical use and emergence of resistance and how we've utilized that information clinically. So ceftolozane tazobactam, as I alluded to, is an anti-pseudomonal beta-lactamase inhibitor that was introduced clinically in 2014. Ceftolozane is the new part of that combination. It's a new cephalosporin with anti-pseudomonal activity. Tazobactam, something beta-lactamase inhibitor that we're very familiar with, usually combined with piperacillin tazobactam. So preclinical investigations of ceftolozane tazobactam revealed high activity rates prior to utilization clinically. And it really, from 85% to 95% of Pseudomonas, including more difficult to treat Pseudomonas evaluated in these studies. However, what we observed upon use of this drug rather rapidly was the emergence of resistance to the agent when clinically utilizing the agent. And most of the reports, and similarly to what we were finding with the use of the agent, was associated mutations in structural modifications in the inducible chromosomally encoded AMP-C gene that's in that Pseudomonas aeruginosa harbors, are also known as the Pseudomonas-derived AMP-C gene or PDC gene. So one question we had was, can we try to modify, or is there any risk factors or anything that we could do to prevent the further emergence of resistance when utilizing this drug clinically? So we did a case control study of our initial patients for which we treated with ceftolozane tazobactam. There were 28 patients with paired Pseudomonas aeruginosa isolates in the study. The paired is the index isolate prior to exposure to ceftolozane tazobactam, and then a subsequent isolate for which we had where the patient had been exposed to ceftolozane tazobactam on treatment. We divided these into cases and controls, where the cases were the paired patient isolates where we observed an at least fourfold minimum inhibitory concentration increase to ceftolozane tazo versus the controls. We did not see an increase, taking into concern the standard error of AST of antimicrobial susceptibility testing, which is plus or minus 1 doubling dilution. And then we further characterized these isolates by microbroth dilution testing to determine not only susceptibility to ceftolozane tazo, but to other novel drugs at that point in time that may not have been clinically available yet, or we haven't implemented its use, and then whole genome sequencing of the paired isolates to understand mechanisms mediating resistance. So when focusing on the characterization of the isolates, we found in about 50%, so 14 of those 28 patients, we observed an increase in the ceftolozane tazo MIC during therapy. And the common mutations were associated with AMP-C and AMP-R, within the AMP-C, AMP-R region of the AMP-C beta-lactamase gene, or in the DNA X polymerase. The interesting part in the study was, and kind of alluded to a little bit by Dr. Nama, was that we observed cross-resistance to ceftazidime avibactam in the great majority of these isolates. And these were not isolates that were not exposed to ceftazidime avibactam. So the resistance mechanisms that were emerging to ceftolozane tazobactam were providing cross-resistance to ceftazidime avibactam. And that agent was introduced in 2015, and avibactam is the novel component of that new beta-lactamase inhibitor combination, where avibactam has activity against class A carbopentamases and OXA48-like carbopentamases, but not your metallo-beta-lactamases. But the avibactam also has activity against class C, and that's why it could also be used for Pseudomonas treatment. But then we also looked at patient-level variables. Was there anything that we were doing in terms of dosing, administration of the drug, or what types of infections where we were more likely to see resistance to emerge? And what we found was that there was differences in the emergence of resistance depending on the infusion strategy that we're using. So the package insert infusion strategy is 1 hour extended infusion, but we were using 3-hour extended infusion in a few of our cases, and we see less emergence of resistance by using that 3-hour extended infusion. And then we also found that, of course, with no source control, you're more likely to develop the emergence of resistance. And then renal replacement therapy did not become statistically significant, but we also did see some trends there leading that would suggest that we were seeing a higher level of resistance there. But by pairing both the whole genome sequencing and the clinical data level variables, we were able to actually define further and lead to further guidance in our treatment guidelines, both locally at Johns Hopkins, but also our data was used to support, especially outside of the urinary tract, that 3-hour extended infusion for ceftolozane tazobactam that was recommended in the new Infectious Disease Society of American MDR GMB treatment guidelines timeline. So just showing, understanding those mechanisms can help us how we approach administration of these agents to further prevent the emergence of resistance. So kind of going along our timeline here, we spoke a little bit about ceftolozane, ceftazidime, avibactam. We're going to skip over marovaborbactam because it's not really a good anti-pseudomonal drug, but focus on cefiderocol. So cefiderocol is a novel siderophore conjugated cephalosporin. It's got this Trojan horse approach where the siderophore binds iron and it uses that as its invisibility cloak into the cell, because then that iron allows it to use active iron transport into the periplasmic space where it disassociates. And then that cephalosporin, the cefiderocol, the cephalosporin component then is able to reach PBB3, which is its target disrupting cell synthesis. The unique thing about cefiderocol is it has broad MDR organism activity. So as I mentioned, Acinetobacter, Pseudomonas, Steno, carbapenem-resistant Enterobacterales, but also metallo-beta-lactamase producers. So as we published our first study about ceftolozane tazobactam and cross-resistance to ceftazidime avibactam, the question came, do we also see cross-resistance to cefiderocol, an agent that we were going to see introduced clinically shortly? And so we did a very similar study to what I just went over, where we had 16 patients with paired index and subsequent isolates. This time, and these were patients that were on ceftolozane tazo, never exposed to cefiderocol. And this time we're focusing on the MICs to cefiderocol. And we found with 4 of those patient cases, we actually observed an at least 4-fold increase in MIC to cefiderocol with exposure to ceftolozane tazobactam. And what we found is that the great majority of these were increasing in MICs, but still didn't meet that resistance threshold, the break point. Although one case did result in frank cefiderocol resistance. And again, it was these mutations associated with AMP-C, which is kind of concerning, where we have introduction of a new drug, the development of AMP-C mutations that leads to resistance not only to the drug it was exposed to, but to other drugs, new drugs that we had available, like ceftaz-avi and then ceftolozane tazobactam. The one unique or exciting thing here, similar to the story with KPC, where we've seen kind of this collateral susceptibility to meropenem, here we actually seen collateral susceptibility to imipenem relebactam. So when we're seeing these mutations in AMP-C, we're seeing the development of resistance to ceftolozane tazo, ceftaz-avi, and elevated MICs to cefiderocol, but we're seeing decreasing MICs to imipenem relebactam. So in terms of treatment, you might think of, if your patient's been previously exposed to ceftolozane tazobactam and the present represents, then the patient represents, then maybe imipenem relebactam may be a drug that you can consider in that scenario. So these are agents that are currently available, or that the agents I just covered are those that are currently available. We're also doing a current study looking at carbapenem-resistant Pseudomonas aeruginosa in our lab to understand mechanisms of resistance to novel beta-lactamase inhibitors that are coming down the pipeline, ones that you may not have heard of yet, such as zeroborbactam or zidibactam. And what we're seeing, again, these are Pseudomonas aeruginosa from the US, where the great majority of our mechanisms are non-carbapenemase mediated in our Pseudomonas aeruginosa. In this subset that I'm presenting here, there's only one VIM producer out of all the carbapenem-resistant Pseudomonas aeruginosa. So metallo-beta-lactamase producing Pseudomonas are a bigger problem. In other areas of the world, not yet in the US. But you could see here kind of the parent beta-lactam combined with the beta-lactamase inhibitor. And we see very good activity of cefepime zidibactam, as well as cefepime zeroborbactam, ceftolozane zeroborbactam, and then cefiderocol on its own, as well as cefiderocol combined with zeroborbactam. Shionogi just acquired zeroborbactam, and Shionogi is the manufacturer of cefiderocol. And what we're likely to see is the combination of those two, cefiderocol, zeroborbactam, in the future. So that was focusing on Pseudomonas. I'm going to shift gears a little bit and focus a little bit on the Enterobacterales. Now, the question is, what about the activity of Sofidrocol among our carbapenem-resistant Enterobacterales? And as I was trying to validate antimicrobial susceptibility testing device for use to implement clinically to determine susceptibilities to Sofidrocol, I used some of my well-characterized CRE isolates in my lab and found that before we even introduced the agent, there was about 25% of my CRE isolates that were non-wild type. So using the epidemiologic cutoff value here for the Enterobacterales, the reason why and not the breakpoint is because when we were publishing and working on this, the breakpoints had yet to be set by both UCAST as well as CLSI, which is the US equivalent to UCAST. And so we took those isolates and did whole genome sequencing to try to understand, can we identify a mechanism that's mediating these higher MICs to Sofidrocol among this set? And unfortunately, we couldn't find any consistent mechanism, but we did find that our NDM producers were more likely to have elevated Sofidrocol MICs, or the combination of AMP-C, ESBL, porins, and efflux and different permeability mechanisms were leading to it. But there was no specific mutations in iron transporters that are a common mechanism that you're now hearing reporting in the literature post-implementation of this agent. Or two-component regulatory systems that are affected by iron, that are iron dependent. But we did see one association here by comparing those that were susceptible to Sofidrocol versus those that were having elevated MICs, was mutations in the sensor kinase, which is BAES, which is associated with envelope response. So we didn't see any unique mechanism, but did already observe preclinical launch, pretty high level of resistance among just a subset of our isolates. And then we encountered this case clinically. So we had many cases where we've now used Sofidrocol successfully for our CRs, for some, especially NDM producers. We try to reserve ceftaz-avi, meropenem, vaborbactam for our serine carbapenemases where there's activity there. But we did encounter this one case, which we published on, where we actually observed the emergence of Sofidrocol during therapy. And this was a 35-year-old woman living in the United Arab Emirates, and she was on a flight to the United States to seek medical care for a relapse in her leukemia. During the flight, she became febrile, tachycardic, and experienced lower abdominal pain. In the emergency department, a blood culture was obtained, and she was promptly started on cefepime. Unfortunately, her hospital course was complicated, where on day 1 and on day 3, a urine culture and intra-abdominal abscess, we were isolated this very multi-drug resistant E. coli that we identified as an NDM-producing E. coli that was only susceptible to the aminoglycosides, to Sofidrocol, tigecycline, and then intermediate break to colistin, which is essentially a susceptible. That is the way CLSI has addressed prioritization of these newer agents over colistin for therapy. So by putting an I beside it, we kind of discourage its use because all of these novel agents are available for therapy. And so on the 3rd day, she was transitioned to Sofidrocol, and chemotherapy was initiated that same day. Unfortunately, on day 17, she experienced new fevers, and tigecycline added to morphologies of E. coli, where the first morphology we started to see this MIC creep to Sofidrocol sitting at 4, right at that break point of susceptible. Intermediate is 8, resistant 16, and that second morphology was frank resistance, a greater than 32 to Sofidrocol. But you'll also note an increase in the MIC to tigecycline here, which is actually resistant and not susceptible. That's an error on my part. And unfortunately, that second morphology was further recovered from the patient's blood. And when we did whole genome sequencing of these isolates, we identified it to be sequence type 167 on this multi-replicon INC-F plasmid and harboring NDM5. So again, going back to Dr. Norman's presentation, NDM5, it worries us because it's got increased hydrolysis rates for the carbapenems. And here what we observed between the 5 isolates and that increasing MIC was increased mobilization of the element containing NDM5 on that same ink F plasmid from 1 copy to 10 copies. I often get asked, how did you confirm this? We did long read sequencing that helped us make sure that that was truly confirmed multiple copies within this plasmid. And those increased NDM numbers correlated with the increased MIC to sifidrocol. We did further expression studies and demonstrated with increased copies, we're seeing increased expression in NDM5. But also we did some inhibitor studies. So metallo-beta-lactamases require zinc for activity. So EDTA is a chelator divalent cation. So we thought, well, if we take each of our isolates and we have sifidrocol on its own plus EDTA, if you add EDTA, you can inhibit the activity of NDM5. And you can see in isolate 3, 4, and 5, as we add EDTA, you see that zone expand around sifidrocol, kind of restoring the activity of it a little bit. So that definitely showing that the contribution of increased copy numbers and expression at NDM5 was leading to sifidrocol resistance in this bug. We also did variant mapping to look at other known mechanisms, so mutations in iron transporters or 2-component regulatory systems, etc. And we didn't see anything consistent across the 5 isolates. And so we thought it contributed a minor role, the resistance is mostly contributed due to the multiple copy numbers. So on day 36, the patient was transitioned to ceftazidime, avibactam as trianam for therapy, and she successfully recovered. And so why ceftazidime, avibactam, and astrianam? Well, as we mentioned before, metallo-beta-lactamases hydrolyze all beta-lactams except astrianam. The problem is that metallo-beta-lactamase producers often harbor other beta-lactamases that then can hydrolyze that astrianam. But the avibactam component of ceftaz-avi will inhibit those other beta-lactamases, thereby restoring the activity of astrianam. And so we were looking at methods to determine the activity in the laboratory for ceftazidime, avibactam, astrianam, and there was these synergy methods, but there's no good correlate to outcomes. And so we developed a broth dissolution method where there's 5 mLs of cation-adjusted Mueller-Hint broth. You have a 30 microgram disc of your beta-lactam astrianam that gets diluted into the 5, gives you 6 micrograms per ml, which brackets the 4-8 susceptible intermediate breakpoint to astrianam. And then you have a disc of ceftaz-avi 30-20, which gives you 6/4, where 4, avibactam is always held constant at 4 in susceptibility testing. And then you can add both together, and that sits right at that astrianam breakpoint, thereby allowing you to do an MIC-based susceptibility test rather than looking for kind of the zone of hope between the 2 discs in a synergy method. And so this method has been further developed and endorsed by CLSI through a multi-center study. The broth dissolution method will be endorsed in the CLSI M100 S34 document coming up in 2024, January 2024, as a method for susceptibility testing for the combination. So the ceftaz-avi astrianam combination is not yet clinically available in the US, and that's why clinicians often use the 2 agents together separately. And the reason why we need a susceptibility testing method is because we're starting to see resistance to that combination as well. And again, in this ST167 NDM producing E. coli, where we observe mutations, insertions into the PBP3, the target of astrianam, thereby astrianam is no longer effective, knocking out that combination for these metallo-beta-lactamase producers. In this particular isolate, the patient had traveled to an area of endemicity where we're starting to see more of these mutations. And then we also observed a mutation in the iron transporter to sifidrocol. So just very quickly, I'm going to talk to you about the new kit on the block, the one that most recently got FDA approval, and I'm not sure about availability in Europe yet, but sulbactam durlobactam, which is an Acinetobacter baumannii focused drug, where sulbactam is a acts as a beta-lactam, and then the durlobactam is a DBO, a beta-lactamase inhibitor that has activity against class A and D oxotypes, which is important, carbapenemases and acinetobacter, but also class C beta-lactamases. And so this was a recent case that we just experienced, a 40-year-old woman with congenital hydrocephalus with VP shunt dependency who underwent an elective surgery. Unfortunately, when her shunt was placed a week prior and was had to be removed because of distal proximity with infected fluid with placement of an external ventricular drain. She spiked fever, and so LP, a lumbar puncture, was performed and CSF was collected. And from day 1 to day 12, intermittently within day 1 to day 12, we isolated this highly resistant, carbapenem-resistant Acinetobacter baumannii. You'll notice that the only thing susceptible here is cefidorachal. So the patient was started on cefidorachal and high-dose amsulbactam. Unfortunately, she was not clearing despite susceptibility to cefidorachal on repeat cultures. And then on day 14, we started the patient on sulbactam, durlobactam, and or day 12, sorry, and she cleared almost immediately the infection. The question is this a clinical failure or is it penetration into the CNS? We did just get WGS results that revealed that there are mutations associated with cefidorachal in this isolate, so it could also be the susceptibility testing methods. The one thing is susceptibility testing with cefidorachal is difficult. Anyhow, this case we'll probably publish this case, but just showing sulbactam, durlobactam did penetrate the CNS where there's not good data so far on the pharmacokinetics of sulbactam, durlobactam. So coming back to my slide, my title, new agents, no problem. Unfortunately, there's still a problem, and there will continue to be as we introduce these new agents. We just need to be strategic on how we use them to try to prevent further emergence of resistance. And so I hope I was able to convince you all to studying the mechanisms of antimicrobial resistance, both pre and post clinical launch, allows us to understand how best to use these agents clinically and devise laboratory testing strategies. And by combining clinical and AMR data, mechanism-based data, we can further define risk factors to try to prevent the emergence of resistance. So I want to thank you all for your attention, and again for the conference organizers for inviting me here to speak. If you have any questions, I'm always happy to receive any emails. So thank you, and any questions?